Okay, wonderful. Well, welcome everyone to the AAD 2026 Congress Highlights on Psoriatic Diseases. My name is Lourdes Perez-Chada, and I am a dermatologist at Harvard Medical School in Boston, Massachusetts. And I will be moderating this session together with Fabian Proft. Hi, Fabian. So we're very excited today to share the highlights of the most relevant abstracts focused on psoriatic disease that were presented this year at AAD 2026. If you're new to this session, this is a virtual conference that we host 4 times a year after AAD, after EADV, ACR, and EULAR. And in the panel, we typically have dermatologists and rheumatologists so that we can exchange our knowledge, thoughts, and questions on these topics and make this really a truly interdisciplinary experience. The way these sessions go is we invite 3 young GRAPPA members to work together with 3 senior GRAPPA members to prepare the most relevant presentations on basic science, on clinical highlights, and on treatment topics. And so with that, we welcome you all, and we're going to move to the next slide. And Fabian, if you want to take it from here.
Yes, thank you so much, Lourdes. So also welcome from my side. This is always a real pleasure for me to have the opportunity to join and listen to the brilliant presentations by the young Grappians that were supervised by senior GRAPPA members when they were doing a very hard job selecting the most relevant abstracts or sessions that have been presented at the latest conference. And especially here, because at AAD and EADV, I'm mostly not able to join as a rheumatologist, so I can get the first-hand expert knowledge, what was discussed, what was presented, and also hear expert thoughts on this selected presentation. So I'm always really looking forward, and I hope this is the same for you, and looking forward to hear your thoughts and questions. And for this, it's really important because you can see here the agenda, and we will kick it off with the basic science highlights that are going to be presented by Ahmed Ugaratilan, who was supervised by Wilson Liao on this. Then we have 5 minutes of Q&A where you are able to just ask your questions in the Q&A section that you can see in your Zoom screen below. So please write any questions you might have into the Q&A, and we will direct them to the speakers and experts, and we will be happy to discussing them with them. Then we have the treatment highlights that are going to be presented by Yusuf Can Edek, who was supervised by Laura Savage. And then we will have the clinical, again, Q&A. Then we have the clinical topics to finish up that are going to be presented by Daniel Becerra Arias, who was supervised by Manuel Franco. And we have a special guest again, Suzanne Grieb, who is a GRAPPA PRP and currently chairing the PRP group of GRAPPA, and she will contribute with the patient perspective. And we're really excited to have this expert faculty here with us today. And we are looking forward to the presentations, but also getting your experiences, questions, and thoughts in the Q&A. So without any further ado, I think we can get started. And Ahmed, the stage is yours. You can share your screen and your presentation, and we are looking forward to what you and Wilson prepared as the most relevant highlights from AAD 2026 on basic science on psoriatic disease.
Thank you so much, Fabian. Welcome all. So today we will present the latest selected abstracts from AAD 2026. So I am glad to be supervised by Dr. Wilson Liao. It was a privilege for me. And yes, these are 3 topics we selected, so I hope it will be interesting for you. And these are our disclosures. And yes, this is our first study. So in this study, the researchers focused on if we blockade IL-23 and 23 at the same time simultaneously by a bispecific antibody, can we get a better results? So before starting, I'd like to focus on the pathogenic rationale. So as we all know, psoriasis pathogenesis actually is a self-amplifying inflammatory loop. And in this loop, IL-23 serves as an upstream immune activator, and IL-22 leads to keratinocyte dysfunction and hyperproliferation. So before the main study, the researchers shared their preliminary results. So to be start with, so in these studies, they used both interleukin-23 induced rat psoriasis model and imiquimod induced psoriasis model. So in two different models, they studied to show that if we blockade IL-22 and IL-23 at the same time, we can get better results. If we look at the graphs, both in ear thickness and PASI results, as we can see, individually IL-22 and IL-23 inhibition give similar results. But if we give these two individual antibodies separately at the same time, we can have better results. So, further aim to produce a bispecific antibodies. First, they wanted to produce a new IL-22 inhibition pathway besides fezekinumab. As we all know, fezekinumab use IL-10 receptor beta epitope of IL-22, but this new in-house antibody it aims IL-22 alpha receptor epitope. So as we can see from the results, they have similar in vitro efficacy. So after they have these two different IL-22 antibodies, they used risankizumab and another IL-23 inhibition candidate. They produced two different bispecific antibodies, AIM both IL-22 and 23, and they have again similar in vitro efficacy if we look at their EC50 results. So when we look at in vivo efficacy of these bispecific antibodies, here we can see the IL-23 mouse model. As we can see from the results, again, ear thickness and PASI results, these blue and red lines show that if we give IL-22 or IL-23 inhibition separately and individually, we have some results, but modest results. If we give these two antibodies separately but individually, we have better results. But if we use bispecific antibodies, it seems that we have a better result. The similar results also can be seen from the PASI results. Also, researchers showed the similar results from histological studies, and they show that bispecific antibodies reduce epidermal thickness. So, to conclude, if we inhibit both IL-22 and IL-23 at the same time, we have better results. But if we inhibit them by bispecific antibodies, we have better results in rats. So it's a really promising therapeutic strategy, especially for maybe difficult to treat psoriasis patients. So it was our first study, and let me start our second study. So in this study, it comes from New Orleans. So in this study, researchers aim if we inhibit IL-17A and C receptor complex, still there is remained inflammation, but can be inhibit this remained inflammation by IL-17A and D receptor complex inhibition. So to remind, as we all know in psoriasis pathogenesis, the most important maybe pathway is IL-17 ANC receptor complex. I will call it IL-17 RNRC. But we are not sure about the downstream results of IL-17A and D inhibition. So in the study, they want to show if it is effective or not. So to study this pathway, they studied both in vivo and in vitro. For in vivo studies, they used three different mice strains. First, they knocked out IL-17 C receptor globally, and in the second model, they they knocked out IL-17 only in fibroblasts and the wild type. For in vitro studies, they used dermal fibroblasts from IL-17 knockout mice for in vitro studies. And again, to switch on and off IL-17 D receptor complex, they use siRNA technology. So first, if we look at in vivo results, as we can see, if we knock out IL-17C receptor complex globally, we can see significant decrease in neutrophil recruitment. But we cannot see similar important results from different cell lines. But interestingly, again, stromal line IL-C receptor complex inhibition didn't produce a significant results. So if we look at the in vitro results, again to remember, they used globally knockout IL-17C receptor knockout mice. So in these cell lines, there is no IL-17C receptor. But if they give siRNA to inhibit IL-17D receptor complex, we can see from the chart, neutrophil associated chemokines decrease significantly. So they interpret it as if we inhibit IL-17D receptor complex, it can add something to IL-17C receptor complex inhibition. So again, it is important. So because we are not sure about the exact results of IL-17D complex. So but these results show that we should give some importance to this receptor complex. So this is my last study. So in this study, actually, it's interesting, I think. So if we derive or change psoriasis severity via reprogramming lipid metabolism. So to start with, just I want to remind and give some background information. Fatty acids binding proteins, especially 5, is quite important for in metabolism and inflammatory signaling. Also, it is we know from the previous studies, it's highly upregulated in psoriatic skin. So, but we are not sure about its role. If we increase it, will we have a stronger psoriasis phenotype or not, or it will affect obesity or metabolic results? We don't know. So to answer these questions, the researchers generate a keratosis-specific fatty acid binding protein 5 overexpressed mice strains. And then when they looked at the results against in psoriasis models, these new mice models produced a thicker epidermis. So it represents acanthosis maybe in clinic. So yeah, so they interpret as this overexpression leads to acanthosis. Again, they continued their in vivo studies, and when they use again imiquimod induced psoriasis model, we can see from the pictures these keratinocytes, fatty acid binding protein 5 overexpressed model. We can see higher PASI and redness and scaling and thickness results from the right. Also, they had some extra results, but they haven't shown all of them in the abstract. So first, these overexpressed models, even though they overexpressed fatty acid binding protein 5 systematically, it doesn't lead obesity phenotype. But again, it was important in skin. They showed that if they fed these mice with high-fat diets, they show earlier skin inflammation. But if they don't use imiquimod model or any other model, they didn't see any spontaneous skin changes. So before concluding, I want to highlight a study. So to maybe to better understand the results, we can use this information. We all know tissue-resident memory cells are quite important for psoriasis pathogenesis and for its recurrence. So, and interestingly, these TRMs mostly used, almost maybe mostly or exclusively use lipids metabolism, and they highly express fatty acids binding protein 4 and 5 and C36. So it is important that fatty acid binding protein 5 is quite important for TRM persistence in psoriatic skin. So from these preliminary results, maybe we can see that, or we can say that fatty acid binding protein 5 can be an amplifier in psoriasis, but it's not a primary driver because we didn't see any spontaneous skin changes in these mice. But if we use imicomod model, we saw epidermal thickening, acanthosis maybe, and greater PASI and epidermal thickness results. So we can conclude that fatty acid binding protein is more important in skin compared to systemic effects, but we need further data. So to sum up, why did we choose these three studies? First, we look at simultaneous bispecific IL-2 and 23 inhibition is a synergistic therapeutic agent for us. And secondly, we looked at IL-17D complex is still important, especially for neutrophil recruitment. So it can be a target in the future, maybe especially for difficult to treat patients. And lastly, we saw that lipid metabolism can change inflammatory results in psoriatic skin models. Thank you so much. Thank you for your attention.
Ahmed, thank you so much for this very comprehensive overview of what has been presented at AAD and what you selected as the highlights from the basic science. So, do we have any questions from the audience? So, again, please feel free to ask your questions in the chat and we will verbalize them to the experts. If this is not the case, I invite definitely Wilson also on stage and contributing maybe with a short expert comment on what has been presented overall at AAD and also on these three specific studies and yeah, most likely clinical relevance, because I think this is always, when I listen as a clinician, listen to basic science, I think it's fascinating. I always have the feeling I don't understand everything, but how this will translate into clinical practice.
Yes, thank you, Fabian, and I want to commend Dr. Adelan for a wonderful presentation on very difficult technical topics. It was really a great summary. I think all three presentations or topics highlight the topic of difficult to treat psoriatic disease. You know, currently we have a number of biologics that we can use in the clinic, but the majority of them kind of have a single target in terms of one specific protein. The first study looked at dual inhibition of two different cytokines, IL-22 and 23, and showed that you could get a boost, right? You could get a better clinical effect in mice or rats when blocking two pathways. And we see that, you know, with IL-17A versus IL-17A and F dual inhibition in the clinic, we see better results generally when you block more pathways. And similarly for the second study, blocking the RA-RD complex in addition to the traditional RA-RC complex gives you potentially additional reduction in inflammation. So I think both of those studies highlight the potential benefit of sort of dual blockade, blocking more pathways. And the final study was really nice because we're now very interested about metabolism in psoriatic disease. How does diet play a role? What about, you know, new weight loss medications? And so this is showing the intersection between metabolism and inflammation. So I thought these are great studies to highlight. Thank you, Dr. Adelan.
Thank you so much also for your perspective, Wilson. Really important to hear that. And maybe just, I know that this is rather speculative because we don't have clinical data, but when speaking about new modes of action and new therapeutic pathways, I think it's always important not only think about efficacy, but also about side effects. when using these dual blockades, would you assume that we would have any issues with safety, or what is your take on that?
That's a great question, and I'll definitely also let Dr. Edelin chime in. I think anytime you block more pathways or dual pathways, you do want to be cognizant of potential additional side effects. Of course, these were done in mice, so we would really need the human studies to understand, safety in humans. IL-22 is very important for epidermal thickening, but to my knowledge, it doesn't have necessarily a crucial role in other human physiologic functions. And so, I think it could be potentially safe, is something to try, at least in the clinic.
Wonderful. See two hands in the faculty. Lourdes, your hand was up first, so maybe you can ask your question.
Sure. Thank you so much, Ahmed and Dr. Liao, for putting those presentations together. They were great. So also I have a question about that first study of the dual IL-22 and IL-23 blockade. Because IL-23s tend to do pretty well in psoriasis, right? So we are already seeing really good efficacy outcomes with IL-23. So where do you see this being more useful? Like, would we be maybe like trying to fit a molecule that targets IL-23 in those cases that have like residual disease activity, rather than starting from the get-go with this dual inhibition? Does that make sense? That's one question. And the second question was about if there is any data about IL-22 on the rheumatology space, which I'm not aware of. So if you know it, want to comment on any of those two. To Wilson or Ahmed, whoever feels comfortable addressing any of them.
Lourdes, I would definitely agree that generally the IL-23s do very, very well for most patients in the clinic. However, I mean, maybe I'm biased because I'm at an academic medical center. We certainly see our fair share of folks that you would you put onto an IL-23, you expect really good results, and you're very disappointed after 3 or 6 months where they have a very, very low response. And of course, we're very interested in psoriasis endotypes and sort of different molecular and genetic flavors of psoriasis. IL-23, in the basic science studies, tends to work very well for patients who are HLA-C0602 positive, who have that particular polymorphism. It may work a little bit less well for those who don't have that genetic marker. And so we definitely have a minority, but still a substantial share of patients who don't respond to IL-23. The nice thing about the idea of IL-22 inhibition is that you're blocking far upstream as well as far downstream. Because remember, IL-22 is one of the final steps that causes the keratinocytes to hyperproliferate, similar to IL-17. So I think that concept of blocking upstream and downstream is really nice. The other potential advantage is you think of IL-23 as maybe a slower drug. It takes a little bit while because you're blocking upstream. It takes a while for it to take effect. If you block upstream and downstream at the same time, perhaps you could see faster clinical results.
Faster response. Great, thanks. And Manuel, you have your hand raised, so I'll let you know, ask your question.
Yes, thank you. I wanted to comment on also the dual blockade. Congratulations, Ahmed, for your presentation. I like it a lot. I think there were previous experiences with dual blockades between TNFs and 17s, for example, but there were like safety concerns on the dual blockades. I'm pretty excited about these blockades of 22 and 23 because, as Ahmed showed us, they share the receptor, and maybe in the clinical setting, the safety concerns it's not going to be an issue. And I think definitely the difficult to treat psoriasis is going to have the part of this. And also wanted to comment on the fibroblast study. I think we are now in the moment that we need to see how this is going to be translated into the clinical practice because, as Dr. Liao has studied and mentioning before in past conferences, fibroblasts maybe play this vital inflammatory role in psoriatic skin diseases. That is. Thank you.
Maybe I can make a last
Yeah.
comments. So I think psoriasis studies are quite important because psoriasis is a leader maybe disease in all inflammatory disease. So maybe if we produce bispecific antibodies, maybe it will work on hidradenitis suppurativa or maybe other diseases, we don't know. Also, for precision medicine, for personalized medicine, maybe if we have more drugs, more pathway inhibitors, so we can be more specific for our patients. So I think still it is important to have new drugs. Thank you.
Wonderful. Thank you both so much, Dr. Atilan and Liao, for presenting on the basic science abstracts. And now we're going to move on to our next session. So I will invite Yusuf Kan Edek. He's a dermatologist from Turkey, specializes in medical and surgical management of chronic inflammatory diseases and advanced imaging diagnostics, to share his screen. And he has been supported by Dr. Laura Savage as the senior GRAPPA member. She's a consultant dermatologist and at Leeds and teaching hospital in the UK, and she specializes in psoriasis and hidradenitis suppurativa. So with that, the floor is all yours.
Okay. Good afternoon, everyone. It's a great pleasure to be here, and I'm truly honored to co-present this season with Dr. Laura. Today, we will be diving into treatment highlights from the EAD 2026 Congress. Here you can see our disclosures. Moving to our roadmap for today, we have structured 3 areas: TYK2 inhibitors, novel biologics, comorbidities, and treatments. Let's start with the first topic, TYK2 inhibitors. This class represents significantly evolution oral systemic therapy for psoriasis. Moving on to ONWARD 1 and 2 trials. These are phase 3 randomized trials evaluating envudeucitinib in patients with moderate and severe psoriasis. The study enrolled adults with significant disease burdens, meaning PASI score 12 or higher, and a body surface area at least 10%. Patients were randomized 2 to 1, receive either envudeucitinib 40 mg twice daily, placebo, or apremilast 30 mg twice daily as an active comparator. The comprimary endpoints at week 16 was achieving PASI 75 and SPGA 0 or 1 compared with the placebo. And secondary endpoints, PASI 90, PASI 100, treatment response according to patients' outcomes such as EAT rejection and DLQI. Now look at the baseline characteristics of the patients. As you can see, treatment arms are well balanced across the studies, and study population represents typical moderate and severe psoriasis groups with mean PASI score approximately 20 and 25% body surface area involvement. Also in the red lines, I want to see some things about that. In Asian populations, you can see higher rates, and BMI of the patients approximately 31, reflecting obese patients. And also, 50% of the patients had prior exposure to systemic therapies. If we look to efficacy results from ONWARD 1, on the left, you can see PASI responses at week 16 and 24. At week 16, co-primary endpoints envudeucitinib 40 mg twice daily demonstrated significant superiority, with 67.5% of the patients achieved PASI 75, compared to 18.7% in placebo and 44.4% in the apremilast group. If we talk about the PASI 100 results, on the week 16, remarkable results were achieved. On the right, you can see SPGA rapid and continuous clinical improvement. By the week 24, almost 70% of the patients treated with envodatinib achieved clear or almost clear skin, significantly higher than apremilast group, which stood at 27.4%. And if we look safety profile of the study, envodatinib was well tolerated, and through week 24, serious adverse events and discontinuations were very low and comparable to other groups. If we looked at the side effects, you can see acne nearly 6% and headache was 10% in the envodatinib group at week 24, and gastrointestinal side effects was lower than the apremilast group. Moving forward to another study, Latitude PSO study from the AAD. The study data on the zasocitinib, highly selective once daily oral TYK2 inhibitor. This study consists two pivotal phase 3 trial 3001 and 3002. These studies evaluated efficacy and safety of zasocitinib in over 1,800 adults with moderate to severe psoriasis. As you can see in the study designs, both trials use as proposed head-to-head comparison with apremilast as an active comparator alongside with the placebo arm. The co-primary endpoints were reaching SPG 0 or 1 and PASI 17.5 at week 16. When we talk about the baseline characteristics of the study, the mean PASI score was approximately 20 and body surface area involved was around 25%. And also 30% of these patients were bioexperiencists. Now you can see the efficacy of the drugs. If we look at the graphics, Latitude 3001, 61% of the patients achieved PASI 90 at week 16, and that increased 69% by week 24. Even more, if we look at the PASI 100 rates, at week 24, 42% of patients achieved total skin clearance. This was significantly higher than the apremilast group. What about the safety? In terms of safety, zasocitinib showed consistent profile. Acne was common about 6-7% of the patients. And in the gastrointestinal side effects, significantly lower than the apremilast groups. Also, if we look at the headache, it was nearly 3% of the patient in the zasocitinib group. Following the TYK2 inhibitors, if we look at the novel biologics in the another sections, we will talk about ORCA 002 phase 1 study. ORCA 002 is a novel extended high-life IL-17A/F monoclonal antibody and has a potential 75-day half-life, which is significantly longer than current options. And this study, they found that this molecule can show potential like bimekizumab with requiring lower doses, only 2 or 3 doses per year. And with doses, they saying twice yearly dosing regimes for psoriasis and also in hidradenitis suppurativa can be efficacious, and ex vivo sustained in IL-17 suppressions paving that measure reduction in injection burden. What about the safety? In the safety results, they didn't see any serious adverse events with this molecule. And finally, if we talk about comorbidities and treatment parts, first study was Together PSA study, was a randomized open-label phase 3b study and compared ixekizumab plus tirtapazid group versus ixekizumab. And the patients adult patients was involved to this study, and the main aim of the study was understood is adding tirtapazid near to ixekizumab can be efficacious in the psoriatic arthritis patients. When we look at the baseline characteristics of the patients, the BMI 38 and significantly joint activity and skin lesions were observed in the patients. When we look at the results and treatment efficacy, the primary endpoint was dual goal, reaching ACR 50 and at least 10% white reduction. Almost 32% of the patients in the combination group achieved the findings, but it was nearly 0% in the ixekizumab group. If we talk about the ACR results, ACR 20 was achieved 71.3% in combination group, and it was 48.5% in the ixekizumab group. And the ACR 70 in combination group achieved 15.7% of the combination group achieved the ACR 17, and it was 7.4% in the ixekizumab group. When we look about the weight loss and kinetics differences, 18% mean weight reduction was achieved on week 36 on the combination group, but it was only 1% in the monotherapy group, and also higher minimal disease activity achieved in the combination group. If we talk about the safety of this combination, tirtapazid got some side effects such as gastrointestinal side effects, nausea, diarrhea, constipation, and this was higher, the side effects was higher in the combination group than ixekizumab group. But also there is important point, clinical takeaway in the bottom row, despite this gastrointestinal side effects, this continues due to side effects were remarkably low in the combination group, and it was 2.9%. And if we're building the results from the PCA data with the together PSO trials, this was particularly challenging population, psoriasis, arthritis, and obesity. And in the study, reduction of the BMI and disease activity was very important with the combination. And finally, if we look about the last slide, I want to talk about the current care gap in dermatology. This study was analyzing psoriasis and hidradenitis suppurativa patients who's using GLP-1 receptor agonist. They were analyzed 1,500 patients with psoriasis and HS, and 72.3% of HS patients and 55% of psoriasis patients meet the clinical criteria for GLP-1 receptor agonist therapy. However, we look at the bottom row, only 22% of these patients received the treatments, and only 0.6% dermatologists prescribed these drugs. This represents massive dermatology gap, and dermatologists should be aware of the situations, and bridging this care gap is essential for the holistic management of systemic inflammation and metabolic comorbidities. So thank you very much for your attention.
Thank you so much, Yusuf, for that presentation, and Laura also for working on that. So as before, we invite the audience to post questions in the chat, and the panelists are also welcome to bring up questions. So I see Fabian with his hand up.
Yes, these were a brilliant presentation. So first of all, thank you a lot, Yusuf, to presenting this. This was of particular interest for me as a rheumatologist. First, usually we see the new compounds, the new modes of action first in dermatology, and then we are implementing them in rheumatology. Here it was different because zasocitinib and ORCA have been already seen in PsA patients. Now we see also the data on the psoriatic skin patients, and even a dedicated PsA study. And I think this is really because Wilson was just mentioning this when we were speaking about basic science, but was highlighting the real hype that is around disease management with new therapeutics. I think this is maybe also a little different from the areas where you're living in. However, also a little criticism about the company, because they were doing exactly the same like they were doing in the head-to-head study with creating a new endpoint. And to me, that a patient that is only receiving ixekizumab is not having a weight reduction of 10%. This is not very unusual, so I think this was somehow a trick. However, if you just look at the dedicated joint or skin endpoints, it was still superior, clearly superior to have the combination therapy. So I think this is really might be a game changer for how we treat our patients, and also how we treat our patients in Germany, where the weight loss medications are not on the forefront yet at such a certain stage. But if we are really treating our PsA patients better from skin and joint perspective, I think we need to include them in our treatment armamentarium. I think this is really coming out of this data, and I'm really looking forward to see the full manuscript published. Any other questions from the audience? Otherwise, Laura, you as the senior are also being part of the selection process. What are your thoughts? What is your gut feeling?
Yeah, Fabian, so thank you for making those points. So Yusuf and I chose these particular abstracts because we felt that these represented a real kind of paradigm shift in the way that we do approach psoriatic disease. You know, we typically think of biologics being best. I think the oral small molecules that we've had to date have been a little disappointing, even perhaps so with deucravacitinib. And so that's why we were keen to highlight those data from the other TYK2 inhibitors of Envoodoo and also for Zaso, you know, and actually say they've been explored as well in PsA. So I do, you know, looking at those data, I think, you know, there is a clear step forward from deucravacitinib. And I think, of course, with the introduction of icotrokinra or icotide as well, you know, actually oral molecules that have got biologic-like efficacy are really becoming, you know, a true reality for us. You know, there are some questions to be had here about where these might fit within our treatment armamentarium going forward. You know, Envoodoo is a twice daily tablet that might influence patients. You know, we're seeing quite a lot of headache as well, 10%, whereas with Zaso, I think it was down at 3%. You know, but we're seeing similar outcomes here to what we have seen in previous EADV and AAD presentations for ICO. But then again, you're looking at the safety profiles. Is there a preference of one over the other? And then, yes, we picked the ORCA because we felt that that, again, brings about a conversation about what do patients want. And if, you know, you can only have 2 doses per annum of a biologic, that probably is favorable. I think as a clinician, that slightly causes me a degree of anxiety if a patient were to, say, develop, you know, the eczematous side effects that we sometimes see by blocking ANF, IL-17 ANF, or IBD, and they've got this drug with a long half-life. But I think, Fabian, I'd be interested for your thoughts, because I think in PsA, particularly where you don't want those peaks and troughs, you want more of a steady state. You know, these drugs with, you know, very long half-lives probably will be, you know, very favorably used in PsA.
Yes and no. So I think also in the PsA patient population, we also are somewhat afraid of side effects. So every benefit of a long half-life comes with the downside that if you administer the compound, you also have it in there, so you can't change it anymore. So I think this is always a small path. However, from the patient perspective, and this might be the perfect moment to also ask Suzanne about her perspective, because this is something that the patients really like, right? If they just have to come every 3 months or just every other half year for an injection, I think this is really making them feel close to drug-free remission. And so I think this is really something, if you would ask the patient every 6 months an injection or every day a tablet. I think it's quite clear. But Suzanne, also happy to hear your perspective on this, benefiting from longer half-life, giving you less injections, maybe having the
Absolutely.
fear of side effects, and also, yeah, just how you
Or
see it.
that's in stark contrast to the Enduvu, which is Envudu, which is twice daily. In terms of, I think there's something for everyone. But yeah, Suzanne, it'd be great to hear what you think the patients will make of these new treatment approaches.
Yeah. So thank you. It's always really interesting hearing from you all and learning from these sessions. I don't always understand all of it, but it's really great to learn from you all. Yeah, I think it's, one of the things that I don't know we talk about enough is kind of the mental health impact of just like what it means to have a condition, a disease. And I think, Fabian, you're correct in the sense of having less invasiveness in terms of the treatment, I think can be really helpful in kind of helping patients not feel defined by their condition, not feel as if it's a larger part of their daily life, than than they would want it to be. Of course, we still have side effects. We still have the way that the condition may affect us. But I think if we can remove some of the activities or things that we have to think about in terms of medication, and especially taking, if we're taking a pill twice a day, for example, that can be pretty invasive. And so I think reducing how frequently we need treatment, if it's effective, I think is a really great benefit to patients.
Thank you, Suzanne. That's really helpful to hear patient insights there. And then, of course, Fabian, we talked about the Together study, and I thought it was very interesting that the late breaker was the Together PSA, and the PSO aspect was just a press release. But I think it's to do with internal timelines and so forth moving forward. But interesting still to see those data and the profound benefits in terms of higher ACR responses and in the press release higher PASI responses. I think in those studies, I would have liked to have seen a tirzepatide only arm so we could really try and understand what the tirzepatide is doing. There's theory around modulation of gamma delta T cells within fat, which we know can then produce IL-17. And is it therefore by reduction of IL-17, are you getting the additional benefit above and beyond what you'd get just using ixekizumab to block IL-17A? I think so many questions that then come about from that study, but I think it started that conversation. And I was delighted when Yusuf then chose that final poster, which was just looking at the care gap, because we know we've got these drugs. There is a sense that blockade of GLPs and endocrines are really making a difference in terms of enhancing outcomes. I see that in the patients of mine that are purchasing these privately, and but actually, how are we going to get these into the patients? And I think that was a really important piece of work as well to supplement that data.
Could not agree more, and I think this is really and it was also for me, it was the first time, because so far I have only seen the press release also for the Together PSA study results that the outcomes was favorable, and so it was the first time that I was seeing the graphs and seeing the more granular data. So still excited to have more depth in the full manuscript, but I think this really will be something that we will be talking about in the next upcoming years, as you said, because we will need to get more insights. And also the question, is it somehow mode related? So would it be the same with the TNFI? Would it be the same with IL-23? Even better. So I think this is really something that we will see a lot of things going on in the future. And yeah, maybe having really a paradigm shift how we treat our patients with psoriatic skin disease. So therefore, thank you so much for bringing this to our attention, Yusuf and Laura. Really enjoyed your presentations, and I think we are able to move forward and finish up with Danielle presenting the clinical highlights. And as said, I'm a strong clinician, also treating patients, trying to understand basic science, but really looking forward to what you and Manuel selected as the burning highlights from AAD. And Danielle, you can share your screen and the stage is yours. Daniel, are you there? You're still muted?
Yeah, hold on. I'm having issues with the system that is asking me for the password to share the presentation.
Okay, so you can try to solve this, and we will be quickly. One other thought, going back to the previous presentations, was also when looking at the SASO data, SASO-CiTINib data, having apremilast as comparator, active comparator, was also something where I needed to smile a little, because this is a medication that, yeah, you can use it, but specifically when treating skin disease, apremilast would not be my preferred choice, preferred mode of action. I can still understand, yeah, it is an oral drug and that you can compare it. However, having the superiority over apremilast would not drive me crazy, utterly excited, and make me use a drug like sazocitinib here. So I see your slides, and now we are ready to hear your presentation, Daniel. Thank you.
Okay, hi, I'm Daniel Barquero Orias. I'm a dermatologist here in Costa Rica. I'm a young GRAPPA member, and I was and the senior GRAPPA member that helped me to do this presentation is Dr. Manuel Franco. Okay, so here are our disclosures. And this is the first abstract and poster that I wanted to mention. This was selected as the second place winner for this year conference. The title is The Comparative Risk of Psoriatic Arthritis in Psoriasis Patients on Immunomodulators. Okay, so basically this was a study conducted from January 1st of 2012 and January 1, 2023. They identified psoriatic patients with the ICD codes. They were matched according to demographics, socioeconomic factors, and also risk factors such as obesity, diabetes, hypertension, hyperlipidemia, and other disorders related to alcohol consumption. And it was for a cohort, a comparator with the immunomodulatory agent. They perform a co-hazard Cox hazard models with 95% of confidence intervals, and they assess the 3-year risk of psoriasis of arthritis in these patients. So basically, this was the Kaplan-Meier analysis that they performed. They compare a lot of biologics to each other, and they found out that the ones that decreased the risk of developing arthritis in this group of patients were risankizumab, guselkumab, and ustekinumab. However, with this Kaplan-Meier analysis, they also demonstrate that there is an arthritis-free survival observed also with TNF anti-TNF therapy. The second abstract that I included is the impact of biologic and oral therapies on systemic inflammation in psoriasis measured by the systemic immune inflammatory index. This is an index that we can calculate at our at our practice. Basically, we all we need is an complete blood count. Okay, so this study compared the treatment impact on systemic inflammation. They compare this index using biologics and other traditional oral therapies. They demonstrate that both reduce the risk of system of they reduce the SSSII index in both arms. However, the one that had a bigger reduction was the biologic group. and it was also maintained by 5 years of follow-up. So this study included it was a big study for all the data was recollected from the All of Us research program that included patients from 2018 to 2025. They included patients with biologics, including anti-TNF therapy, interleukin 17, 23, and with the traditional oral systemic, they included patients receiving methotrexate, cyclosporine, and acitretin. And this is the third abstract that we selected from the clinical topics perspective. This abstract is called Prevalence of Cardiovascular Comorbidities and Subclinical Atherosclerosis in Hispanic Patients with Psoriatic Disease. So basically, they measure the thickness of the carotid artery using ultrasound, and they defined as thickening or focal protrusion of more than 1.5 millimeters of the wall to detect those patients that with risk of arteriosclerosis. So basically, this was a cross-sectional study. They included Hispanic patients with psoriasis and also arthritis that meet the Caspar 26 criteria. The recruitment included patients from 2019 to 2025, and the comorbidities, the cardiovascular comorbidities, were recorded from the medical records. So basically, the most important finding is that 40% of this patient had a carotid plaque when assessed with ultrasound. Also, the risk of obesity was half of the patients, close to dyslipidemia, and with lower prevalence of overweight, hypertension, and diabetes. So basically, this is a study. I wanted to include this study because Hispanic populations remain unrepresented in research, and we have limiting accurate risk stratification and target prevention strategies for these patients. Also, to complement the posters mentioned previously, Manuel and I agreed to bring this short information on proteomic and biomarkers from new therapies. So in this study, they analyzed the proteomic of embudezitinib. So basically, in this image, what we can see is a biopsy of the skin. We have here a comparison between the baseline lesional skin that it was marked with interleukin 36 expression. We can see that in both with in placebo and in the baseline biopsies, we can see the positive that is marking a positive expression. So at week 12, we can see that the comparison between placebo and eumbacitinib therapy using twice daily. So we can see that here it loses the expression of interleukin 36. Also here, it's the expression of keratinocyte genes. So we see here that the expression of clusters of 6, 11, 12, and 19 keratinocytes are reduced when using this therapy, We can see also that those levels are maintained after therapy, and we can see that the dose using once daily and twice daily are really close. And here is like this was performed with the skin biopsies. This is the profile of keratinocytes. So here the baseline, we can see that there is that in the baseline profile, it's really close to the one that it's the week 12 lesional skin biopsy. So we see that when using this therapy, the keratinocytes profile really resemble those from the healthy skin. And the last one is the signaling and pathways biomarkers using sacocitinib. So basically here is the pathway of the interleukin 23, interferon pathway, interferon 1 pathway, and interleukin 12. So basically here is a comparison between those patients achieving PASI plus 75 to those who didn't who achieved lower than 50. So basically what we can see here is the expression of interleukin 23 genes, that it's actually lower in the treated patients. And also here it's the similar with interferon 1, and not as much as the ones in the group of interleukin 12 pathways. And this is what I have for today.
Wonderful. Thank you so much, Daniel and Manuel, for putting these presentations together. So we're going to move on to the Q&A on these final clinical topics. I do have a comment before, so I invite everybody to ask, but I'll bring up a comment for one of the presentations. The first one in which you talked about the observational study about preventing psoriatic arthritis, right? So we've seen a few already observational studies moving in a similar direction, right? That IL-23 might seem to have these protective effects. But I always can't help wondering the potential bias in these studies, because if you think about it, if a clinician suspects that a patient might have early signs of psoriatic arthritis, which we do not document in these large data sets, right? They might be already prescribing TNF inhibitors or IL-17 inhibitors, right? And so how truthful is it that we are seeing IL-23 is having a protective effect as compared as like by indication bias, I would say. Not just a reflection, and maybe add that I'm looking forward to the results of the clinical trial that's being done on this space, the PAMPA study, because I think that will give us more objective data to see if there's truly an effect of IL-23s on this path. But I invite you and Franco to comment on that if you want.
I think that we are agreeing the same thing about the bias of the potential bias of this observation study, because we don't have enough data with the TNFs and 17s regarding the protective effect of developing PSA. But I think, and I wanted to Daniel mention this, was on this exact study, the free survival time of PSA with anti-TNFs. And as you can see, this poster that was awarded, and that's an important thing. Thank you, Daniel, for bringing that up. It's that we see also free survival time of PSA with anti-TNFs. So we have to see the prospective studies and the PAMPA studies and the STAR study and all the studies regarding how is possible to definitely prevent developing PSA. I think the terminology is very important because nowadays we're talking more of psoriatic disease, and if you have more skin phenotype or maybe PSA phenotype, every patient has the chance to develop both diseases. So we have to see in time.
Great. And then regarding the other abstracts that you selected, would you like to maybe make some like highlight comments on those other abstracts? Or Fabian, do you want to go first with your question, or is it okay if?
Now it's we can just postpone my question just to comment.
Okay. Yeah. So, Manuel, yeah, just if you want to give us like your take-home messages perspective about the selected abstracts.
Yeah, about the systemic inflammation index. I think it's very interesting to have this index because it's a very easy index to perform. It's I just wanted to mention that it's the platelets plus neutrophils over lymphocytes. I don't know how this index impacts on cardiovascular disease, but it has been studied on cardiovascular disease. So I think we have to start to measure these indexes in our clinical daily practice because we can think about how can this index may impact on cardiovascular disease and psoriatic disease in the future if we start to measure this in the daily practice. That's the other thing I wanted to mention. And regarding the other poster on the prevalence of cardiovascular disease on Latin American population, this is very interesting because we don't have enough data, as Daniel told us, on the Latino population on cardiovascular disease and obesity. And as you can see, more than 40% had plaques on carotid, and 50% of patients had obesity. The Latino population is a very, very specific population with cardiovascular disease. I think we have to put more interested and have to do more clinical trials on this specific population because definitely they are underrepresented. I don't know, Daniel, if you wanted to comment on this.
Yeah, basically what I want to add is that carotid ultrasound is not available for in every setting. So I think that we have to use like indirect findings. For example, this index to see to evaluate the risk of inflammation for these patients.
Okay.
Fabian, you had a question before?
Yes, or it was more a comment. You already realized that I was somehow in a critical mode today, but don't get me wrong, it was just about, while I was criticizing the companies for selecting or trying to make their
Oh, yeah.
compounds look more classy when choosing the comparators or the endpoints. And this was only about the study with the disease progression from psoriasis to psoriatic arthritis. And I think we have seen so many data from observational or registries whatsoever. So sometimes indicating different aspects or even diametrical results. So I think we really need to have a prospective cohort addressing those patients before we can make a solution that one compound or the other is really superior. So my true belief is that if you treat the disease itself effectively, you will have less PSA on the long-term run. However, if one mode of action is even superior to the other, can only be solved by a prospective head-to-head comparison. So this is just my belief, and I would not prescribe IL-23 or IL-17 or whatsoever to specifically reduce the risk of getting PSA. However, if this is the best mode of action to treat the skin psoriasis, and you have a compound that would potentially also address MSK symptoms, I think both are valid options.
Yeah.
Great.
Okay, so are there any other comments from the faculty, or have you in the audience any other questions? Please feel free to put them in the chat. In the meantime, I again would like to invite Suzanne, if you have any further comments, if you have any final thoughts from the patient perspective on the abstracts that have been presented. And I just can make one more comment, because I really liked also how the different yeah, sections were going into each other, because we have seen readdressing things that we have already seen in the treatment, we have now seen in the clinical topics, really showing that these are all connected and intertangular. So, Suzanne, do you have any other points that you would like to raise?
Yeah, I'd actually like to ask a question. So, regarding this last group of presentations and the study number 3, I was really excited when I saw this study being included for multiple reasons, but one being, at least from the US perspective, one of the complaints we often hear, and I feel myself as a patient, but I hear from other patients as well, is our siloing of health and health impacts. And so seeing the work with the cardiovascular disease, made me really excited to have a more holistic view of not just psoriasis, but also cardiovascular health and the connections. And I'm curious if there are ongoing longitudinal studies, because the one presented, of course, was cross-sectional, but are there ongoing longitudinal studies that are looking at the relationship between psoriatic disease and cardiovascular health, whether that's specifically for Hispanics or for other populations?
No, not that I know. Longitudinal, no, not that I'm aware, but I think it's a topic that it has been included on almost every big study on new molecules. For example, they're constantly measuring the cardiovascular risk on patients, but not specifically talking about diseases on cardiovascular diseases specifically. But I think it's important for example, now that you mentioned in the United States, you have a lot of Hispanic population, and it's definitely important to address this specific population in this risk, because every day the Hispanic population is growing in the United States and Europe. It's a reality.
And maybe I can just address a question to the group all. How is it with the GLP-1 agonists in your setting? Are they prescribed by the rheumatologist or the dermatologist? Do the patients have to pay them out of their own pocket? And if so, what are the costs? Because I think this is something that really differs from the setting. So would like to hear your opinion. So in Germany, the costs are rather high, so that paying them out of pocket is not really a good option. And the barriers, because you really have to have obesity, you have to have fatty liver disease whatsoever to have the label to be able to prescribe them. So this is, I think, one of the key reasons that they are not so widespreadly used over here at the moment. But based on those data, that might change. But I would be really curious to hear how you are using them in your setting.
In Colombia, and that was one of the things that we were talking at the AAD in our group and in our Latin American group. I think we are the ones, dermatologists and rheumatologists working in immune-mediated diseases. We are now being called to know GLP-1s and prescribe GLP-1s, because the evidence definitely is growing about the anti-inflammatory effects of these drugs. We are using them in Colombia, but definitely they have to be paid out of pocket by patients. More or less the cost of it's like $400 or $500 monthly. It's a high cost. Not everyone can achieve, but the ones who can achieve and take these medications, I think they are having benefits of using them. Definitely.
Danielle, you're
Here
still
in
muted.
Here in Costa Rica, basically at the private setting, it's really accessible for the patient to buy it out of the pocket. It can be prescribed by the endocrinologist or also by a dermatologist. It doesn't have like to be is restricted for any specialty. However, in the public sector, it's only limited to the endocrinologist, and it's a medication that it has to be bought by the government. Is not included in the official medication list that we can prescribe easily.
And maybe hear about the US and the UK perspective. Laura and Lourdes, how is it for you guys?
Laura, do you want to go first? And I'll offer the floor to Dr. Liao, who's actually prescribing in clinic, because I'm not so, to have more of a clinical perspective, I'll invite him to comment on that.
I think it's a great question. Definitely to date, at least in the Bay Area, it's primarily, I think, endocrine and primary care that is prescribing these medications. But I think there's a growing interest in having dermatologists and rheumatologists take ownership of this and at least be the primary coordinator to either work with the primary care to get these medications prescribed or start to prescribe it ourselves. We we feel that metabolic health is part of psoriatic disease care, and we should also have the ability and knowledge to and comfort level to prescribe it ourselves. But it is quite difficult in the US in terms of insurance to get these medications covered, even if patients qualify based on BMI or diabetes. Many insurance companies are requiring many months of exercise, nutrition programs, and all sorts of things before patients can get these medications. So it is still quite difficult to get these medications covered.
So yeah, in the UK, of course, they're licensed, but everything in the UK has to go through an additional step with NICE, who is our cost effectiveness analysis group, who are not that nice. And so they have approved these, but then because there was a worry about an influx for weight loss and sort of bankrupting our National Health Service, they've put in place a cohorting approach. So currently, GPs, primary care providers, can prescribe them for weight loss in patients who have a BMI more than 40 and 4 comorbidities. So it's kind of shutting the stable door when the horse has bolted to a certain extent. But there is a plan and a proposal to bring down BMI thresholds and the number of comorbidities. But at the present time, it's only primary care providers that can do it. We have been working very hard as a community and patients, managing patients with inflammatory skin diseases just to try and bolster the availability, particularly to our patients with immune-mediated skin diseases, because of the value that I think we anticipate to see and that we do see in patients who are privately accessing these.
Wonderful. And maybe also, again, hearing the patient perspective, Suzanne, is this a topic that is widely discussed also within the GRAPPA PAPs, we know that there is growing interest about nutritional intake, weight loss, weight management, but how about is the perspective about GLP-1? Is it seen as the wonderful drug that will save you from everything and you can just do whatever you want, don't have to die? So really happy to hear your thoughts.
Yeah, so I think the patient perspective is very varied, right? Some people see it as a potential benefit and something that can be really helpful. And I think, that's not only from the benefits of weight loss, but also just from the anti-inflammation characteristics. I think the presentation last year at the GRAPPA meeting on that was really enlightening as a patient, particularly. But I think there's also a lot of concerns about the long-term health implications that maybe we aren't aware of yet. Also thinking about adding more medication, right? Most PSA or psoriatic disease patients are on some sort of medication, if not multiple. And adding medication is always something that I think is a little daunting to think about and kind of contemplate. So I think there's still a very varied interpretation and perspective within patients. And so all of the increasing data, I think, is really helpful. But also, I think it most importantly goes back also to making sure that our providers are having these conversations with us, so that, we all can create our own care pathways that are best for each of us. So it's great to hear about how you all as providers are thinking about these GLP-1s and their place in your practice.
Thank you so much, Suzanne. And I think this is really the key takeaway, that we just have to think about it, that we have to find our pathways. And based on the data that we have seen today, I think this is really something that we need to take into consideration also for our patients with psoriatic skin disease and obesity. But we are very lucky that Cheryl Rosen is also here in the audience, and she can share her perspective that she has from Canada. So Cheryl, thanks for jumping in, and
Well, thank you for considering it lucky that I'm here. Thank you. So in Canada, healthcare is by province, and so I can speak for the province of Ontario. The GLP-1 semaglutide would be covered in Ontario if you have diabetes, and not if you have obesity by the government drug plan, but private insurance may pay for it. That's the current situation. So it's not so much for obesity at this point, more for diabetes. Yeah, and anyone can prescribe it. A dermatologist can certainly prescribe it. Family doctors can prescribe it. Endocrinologists, of course, too.
Thank you so much, Cheryl, because I think, again, because it differs from setting to setting and country to country, we are able to learn from each other. So those that have more experience about how to prescribe, and also maybe monitoring side effects of combination therapies, because I think also when looking at the data that we have just seen today, it's not only effective, but also having higher side effects, safety issues in the combination therapy. So this is something that we have to take into account. And there's one other question coming from the audience. Should this data encourage patients to proactively seek cardioprotective medications, such as statins, even if levels of LDA, lipids, etc. are not overly high? I'm happy to hear the perspective from the audience. Personally, I think it should be in a slightly different way, that you should include also monitoring the ultrasound in your overall assessment. However, I think you should mainly, the lab parameters are the ones that you can also monitor over time, and where we know that the statins or lipid lowering therapies are effective. So I think this would be my main takeaway. But happy to hear from Manuel and Danielle and the rest of the faculty.
I personally think that definitely patients have to seek about the overall cardioprotective effects of any medications, because nowadays we know that patients are more aware that severe psoriasis and psoriatic arthritis is an inflammatory and has cardiovascular risks. So if a patient knows this, uh, definitely they should seek about using statins if, for example, they have dyslipidemia, and it has been more than widely demonstrated that statins has a cardioprotective effect. So definitely, I agree with that sentence.
Also, for these GLP-1 inhibitors, we are seeing what is happening with the interleukin 23, that now there are like oral options. So it has to be taken into account also for patient preference, as this medication can treat different comorbidities, for example, diabetes and obesity at the same time, and also avoiding having polypharmacy. We having just taking one medication for both of the comorbidities.
Yes, thank you. And there's another comment again from Cheryl that she thinks it's important to also include lipoprotein LP small a along with the rest of the lipid profile. I do agree. And I think this is something that is also coming more and more to our attention. However, from my personal perspective, I can share that I have rather okayish cholesterol levels. However, my LPA is elevated, so I'm in somewhat doubt what do I have to do with it now. What can I do, because there are no therapies that are able to lower LPA at the moment. So I think this is something that we have to learn more in the nearer future. But again, it shows really how connected this is, right? Obesity, cardiovascular management in our patients with psoriatic skin disease. And I think this is something that is so important that we, as the experts taking care of those patients, dermatologists, rheumatologists, are not just focusing on skin and joints, but we have to see the patient holistically. And here I think all these comorbidities are a real important aspect. And therefore, I really thank you for bringing those to our attention today. And I really enjoyed your presentations. And I think because we are running out of time already, Lourdes, do you have anything
No,
that
I
you
was
want to add?
trying to figure out how to share an article on the chat because there is a recommendations paper on the how to approach patients from this cardiovascular perspective from Dr. Ware and Dr. Garshnik that was published last year that I think might be helpful to the person who asked how should we be handling. So if I put it on the chat, does everybody see it? Let's see. Host and
No,
panelist says
only
only
we.
us. So if I put it in the
But maybe
Q&A,
we
maybe
can
the
put
same.
it. Maybe we can put it in the Q&A. I think this could work. I will try this.
Okay. Um, maybe if I put here answer live to this. Um, hmm. Okay, I'm not very good with technology, but well, we'll see how we can share it. But if you want to look for it, um, it was published in JPPA and it has a very nice figure. Also, it's called Practical Recommendations on Cardiovascular Risk Evaluations in Patients with Psoriasis and Psoriatic Arthritis. This is part of the BPACMAN group that put out this article, and I found it as a very useful resource. So if you're interested, you can look at that. And despite the fact, I wanted to comment that while we are all trying to learn how to prescribe these drugs and when they're appropriate and trying to interpret the guidelines from this and that specialty, I think that it's going to be key to have this interdisciplinary mindset when approaching these patients, who works as a team and not trying to own everything, because there will always be something that we're maybe have questions. So maybe building that team, learning and feeling comfortable on how to prescribe them for sure, but also have that focus on building that interdisciplinary team for treating these complex patients should be part of the core conversation, right? Like have the cardiologist friend and the endocrinology friend and treat patients holistically. With a lot of mental health support too, because even approaching these conversations about obesity with patients can be challenging, and so on. So, well, thank you all so much. It has been a fascinating session. We covered so many topics and so much like late breaking research that I think we all learned a lot. So thank you so much to our young GRAPPA members or senior GRAPPA members for all the effort put towards these presentations, the Cheryl who joined the panel the last minute, Susan, our PRP, all the admin team on the background, especially Annie Spangler for all her support. And Fabian, thank you so much for your room perspective and hosting with me today. We look forward to seeing you at our next session, which will be after Euler, right?
Absolutely. We will be in London for Euler 2026. Hope to see you there as well, Laura, as local guest. You're
I will.
nodding, happy to do that. And then we will be presenting the highlights that were selected and curated from the room perspective on the most relevant topics from Euler 2026. I would make a guess. I think that we will see the combination therapies with ixekizumab and GLP-1 agonists there as well. Maybe not as a late breaker, but as a plenary session. And I think that we will be discussing them here in the Virtual Congress highlights on June 17th. So mark your calendars. And again, Lourdes, it was a real pleasure hosting this together with you and the whole session with all these brilliant presentations, and you in the audience for your interest. Thank you so much, and have a wonderful rest of the day wherever you are.
Thanks, everyone.
Thank you so much, everyone. Nice to see you.
Thank you. Thank you so much.
Thank you. Take care.
Thank you.